Welcome to Code Blue, Healthcare in Crisis. Healthcare reform is the issue of the day, dominating conversations from the kitchen table to the halls of Congress, from mainstream media to the internet. Just about all that everyone can agree on is that there are big problems with healthcare as we have come to know it in our country and in our state. The challenge is finding a way to address those problems without destroying those parts of the system that are working. In the next hour, we'll examine the nature of the healthcare crisis through statistics and personal stories. You'll hear from doctors, nurses, patients, and advocates who will give their own perspectives on the current system based on their direct experiences. We will also look at the prevailing trends to determine if this is just a rough patch we are going through or if there are fundamental problems which threaten the ability of the system to continue to function. We will then look at the proposed reforms to determine if they address and respond to the current crisis and if the proposed reforms can succeed in changing the current direction of the present system. Finally, we will look at some of the claims being made by opponents of these proposed reforms and what the implications might be if the current effort to change the present system does not succeed. The current system. In the 6½ decades since the end of World War II, Americans have primarily relied on a system of private insurance to cover their healthcare costs, and most of that insurance came in the form of employment-based healthcare. While no one would argue that there is much to be admired in the way that our healthcare system has developed, it also has deficiencies that make the care provided less accessible while at the same time imposing economic burdens on American businesses that their competitors from Europe and Asia do not have. The United States remains the only major industrialized country in the world that does not have a national health system to address the needs of working-age adults. Over decades, as the cost of health insurance has increased, our employment-based health insurance system has put a financial burden on American businesses that do not show up on the balance sheets of their competitors. For example, the former head of General Motors said the firm paid more than $100 billion in healthcare costs in the decade leading up to its recent bankruptcy. While there were certainly other factors contributing to the collapse of GM, the fact that it had to compete against foreign companies that were not required to shoulder the full burden of employee healthcare needs put it at a competitive disadvantage. American healthcare is the most expensive in the world, outstripping costs in all other countries by significant margins. But are we getting what we're paying for? The Commonwealth Fund, a nonpartisan organization that has been examining healthcare trends in the United States and other industrialized countries for decades, funded a study comparing the levels of preventable deaths in 19 countries. Researchers found that the United States finished last in terms of preventing avoidable deaths prior to the age of 75. The study included 14 European countries, Canada, Australia, New Zealand, and Japan. The report estimated that the inability of U.S. healthcare to match the improvements made in these other countries in matters of basic access and care means that more than 100,000 Americans die each year. So, while healthcare in this country is more expensive than in any other country, there is evidence that the system is failing to deliver essential care when compared against other, less expensive systems. When the employer-based health insurance system emerged in the 1940s, companies provided basic health care coverage for their employees and their dependents. At first, the cost of this system was borne almost entirely by the companies. As time passed and costs rose, most companies and governments have made employees share the cost of the coverage. In addition to paying some portion of their premiums for that coverage, employees and their dependents were required to pay either a deductible or copay as part of covering the increased costs of treatment delivered under the company-sponsored program. Over the course of the past 2 decades, costs have begun to rise faster. Growing numbers of companies have found that they can no longer offer healthcare insurance to their employees at all. Current estimates are that just over 50% of businesses now offer health insurance as a benefit to employees. Among small businesses, the percentages are starkly lower. Companies that cannot offer health insurance to their employees put their own economic prospects at risk to nearly as great an extent as that faced by those uninsured employees. Dr. Mike Robichaux is a physician in Raceland, Louisiana. He explains that uninsured workers are less productive and can frequently be distracted by the financial burden that medical costs impose on them.
It's very difficult for a businessman to have people that aren't insured because his people are subject to bankruptcy so easily, and it helps their ability to be dependable employees.
The financial burden Dr. Robichaux mentioned is confirmed by the statistics. Research has shown that more than 60% of all bankruptcies in the United States involve bills arising from medical expenses. Even more disturbing is the fact that 80% of the bankruptcies involving medical expenses involve people who had health insurance. Bob Rivera of Lafayette is one of the people who could not avoid bankruptcy as a result of being hospitalized for a problem with his kidney.
Approximately 1999, the company I was working for ended up closing their doors, and I was without insurance. At this time, I was offered COBRA, but at my age, the cost was prohibitive, and as a result, I took my chances and decided to pay the rent. I had a medical experience. It was a blood clot on the kidney.
The rise in medical costs is being driven by a number of factors, not the least of which is the profitability of the major players in the industry. The pharmaceuticals industry profit margins outstrip those in other industries, and those profits are extracted from the bills that are generated when patients seek care. One former health insurance industry insider says that costs are also being driven by the behavior of health insurance companies themselves and their desire to satisfy Wall Street's push for even better profitability. That push for profits has led for-profit health insurance companies to raise premiums to shed customers, to deny coverage to those with pre-existing conditions, and to even revoke coverage from people who have been diagnosed with a serious illness. In recent years, the rising tide of costs and the large number of uninsured has created a new dynamic that is undermining the sustainability of the employer-based health insurance system. People who don't have health insurance, or those with coverage but with high deductibles or copays, avoid doctors for routine visits. America, like other industrialized countries, has a problem with chronic diseases. These diseases, diabetes, high blood pressure, heart disease, kidney disease, stroke, are diseases that can now be managed. However, the high cost of care discourages people suffering from these diseases from seeking care until the symptoms get too bad to ignore. At that point, the care needed to stabilize the patient's condition is more expensive, and their capacity to enjoy life and work productively can have been seriously diminished. Our current system's poor response to chronic disease imposes a hidden tax on businesses in the form of lost productivity of workers, in addition shortening the lives of many of those with these diseases. Cynthia Austin of Lake Charles is uninsured. She tells what happened when she went to an emergency room for treatment of a cough.
And I was sick and I was coughing, and I had went inside the emergency room. Although I didn't have insurance, they did a mild examination. The only thing he did was listen to my chest, and he determined then it's only I had a cold. And I started to feel worse in that week, and I had went to St. Patrick Hospital, and they did a chest x-ray and found out I had pneumonia.
Moriba Karamako of Brobridge heads the Louisiana Consumer Healthcare Coalition. He said Cynthia Austin's experience is typical of those without health insurance coverage.
When people are without insurance, they delay treatment. When they're not delaying treatment, they're not afforded access to early testing and screening that allows you to catch problems early. Someone without insurance is more likely to have a prostate cancer diagnosis when it's in the later stages of development, or a breast cancer diagnosis, or a cervical cancer diagnosis, or some other ailment.
Dr. Keith Ramsey is the medical director for a federally qualified health center based in New Iberia. Dr. Ramsey says that the lack of affordable access to care explains the high rates of death from chronic diseases that makes health measures in Louisiana compare so poorly to the country as a whole.
When you look at those chronic diseases, diabetes, hypertension, hyperlipidemia, those metabolic patients.
Even if these patients are able to access care, it does not mean that they are able to pay for it. And covering the costs of care provided to those with limited or no ability to pay for that care is a major contributor to the rising cost of private health insurance, both for companies and for individuals and families. To recover for losses associated with uncompensated care, hospitals and other medical providers will raise the costs of services charged to those with coverage. Because reimbursement rates for Medicare and Medicaid are set by the federal government and the states, the deepest pockets with the ability to absorb and pass along cost increases belong to those patients with private insurance. The process is known as cost shifting. It is an essential component to the financial survival of many hospitals and clinics. It is the reason why common things like over-the-counter medicines will cost seemingly ridiculous amounts in hospitals. Cost shifting, then, acts as a hidden tax that those with health insurance pay in order to cover the so-called free care that the uninsured and poor sometimes get from hospitals, doctors, and clinics. Most recent estimates are that cost shifting imposes a hidden tax on every health insurance policy sold in this country that amounts to between $900 and $1,000 per policy per year. Dr. Ramsey points to one clear example of how that hidden tax reveals itself.
And the hidden tax is a Tylenol that the hospital's going to charge you $8 for one Tylenol. If you look at an itemized bill from the hospital.
Suddenly that supposedly free care is beginning to look very expensive. But there are problems beyond the cost of care that indicate fundamental problems with the current system, particularly in the health insurance markets. As is the case with other forms of insurance, health insurance is regulated on a state-by-state basis. This approach benefits the health insurance companies, which can bring their considerable resources to bear to influence the decisions and actions of state regulators. Common practices in the health insurance industry raise serious questions about whether the industry really sells insurance, or if it is engaged in something more like the Ponzi schemes and other scams that have been proven rife in the financial services industry. Two practices in particular raise fundamental questions of fairness and equity. The first is the ability that companies have to deny coverage to people with pre-existing conditions. The practice effectively denies coverage to millions of Americans and thousands of Louisiana citizens with frequently dire consequences. It also has the effect of inflating the size of the pool of people without access to health insurance. Rosalind Davis was a successful real estate broker in Baker, Louisiana, when, in 2007, she was diagnosed with breast cancer. Because she suffered from Crohn's disease since the mid-1990s, she had been unable to buy health insurance coverage.
Well, my story is basically just having a fight and a battle with cancer, and at the same time when I was diagnosed with cancer, I ended up without health care, without insurance, because of the fact that I had a pre-existing condition, and that pre-existing condition is Crohn's disease.
The other ethically questionable practice is known as rescission. That occurs when a company drops coverage for a patient at some point after a disease has been diagnosed or a regimen for treatment has been prescribed. It is a practice that the industry staunchly defends despite the harm it causes its erstwhile customers. In many instances, these are the cases requiring extensive and expensive treatments. The practice of rescission casts an ethical cloud over the health insurance industry and raises fundamental questions about whether what they sell is actually insurance or merely another way for highly profitable corporations to gain access to the money supply of ordinary citizens. So the crisis in healthcare comes down to matters of access, and in the United States, we ration access based on the ability to pay for either insurance or care. The barriers to access center on cost, compounded by health insurance industry practices that deny people access to the care they need, sometimes even the care they have paid for. The consistently upward spiral of costs have pushed the system to a tipping point. The employer-based system of providing insurance is faltering under the burden of unrelenting cost increases that only worsens as more people move into the ranks of the uninsured. Part 2. The Crisis in Louisiana Healthcare. It is not news to say that Louisiana healthcare is in crisis. For a long time now, the state has consistently ranked at or near the bottom when the quality of care delivered here is compared against that in other states. The poor rating of healthcare in Louisiana could be a sign of things to come nationally if current trends continue. In fact, the future of U.S. healthcare could look a lot like healthcare in Louisiana if things don't change. The problems with Louisiana healthcare start with the fact that a large percentage of our population is uninsured. The LSU Public Policy Research Lab conducts annual surveys on health insurance in Louisiana on behalf of the Louisiana Department of Health and Hospitals. That annual survey has found that the rate of uninsured adults between the ages of 18 and 64 in our state has fluctuated between 20 and 25% over the past 5 years. Without insurance, the lack of money becomes the chief barrier to gaining access to health care. Dr. Mike Robichaux of Raceland says that the lack of health insurance is a major contributor to the state's health care problems.
We know when people lack insurance, they don't live as long. They get illnesses.
Dr. Keith Ramsey says that the state's high levels of deaths from chronic disease is proof that the cost of care is the chief barrier to access.
Well, it really means that we are doing a poor job of getting access across the state. You can compare that to the neighbors. Compare that to Texas.
Chronic disease has an impact that reaches beyond the individual and their immediate family. According to a study by the Milken Institute, chronic diseases impose a hidden tax on businesses by decreasing the productivity of workers. Those workers might have a chronic disease, or a member of their family might suffer from such a disease. Workers with chronic diseases can miss days of work, or they might miss work to take the affected family member in for medical attention. Whatever the particular circumstances, the Milken Institute estimates that chronic diseases impose a $22 billion annual burden on Louisiana businesses. Because such a large percentage of people are uninsured here, it means that people with chronic diseases don't get access to the treatments that could allow them to live a decent quality of life. Instead, the uninsured with these diseases avoid seeing a doctor for as long as they can because they can't afford the cost of a visit or the medicines that would be prescribed. As a result, the diseases run uncontrolled until the symptoms get too bad to be ignored. Those patients usually end up in hospital emergency rooms where they can get free medical attention. Hospitals are obligated to provide care to patients who present themselves at their emergency room for treatment. Although many patients using emergency rooms as primary care clinics are uninsured and don't have the means to pay for the care given, hospitals must recover the cost of the care they provide. They do so by employing a process known as cost shifting. Each year, patients in emergency rooms and others leave Louisiana hospitals about $1.3 billion in unpaid bills. Medicare and Medicaid reimbursement rates are set by the federal government and state government, respectively. With those rates fixed, hospitals turn to the only other deep pockets that they can tap, those with private insurance. Hospitals charge private insurance companies higher rates for services in order to make up for losses incurred providing care to the uninsured. A study financed by the Center for American Progress estimates that every health insurance policy in Louisiana carries a hidden tax of between $900 and $1,000 to help pay for the cost of care provided to the uninsured. That tax is not listed anywhere on the policy. It is just cost built into premiums based on the charges. So cost shifting is part of the process that is driving up the cost of private insurance in Louisiana so fast that it is outstripping the ability of companies and families to continue to pay. In this decade alone, health insurance premiums in Louisiana have increased by 82.3%. During that same period, median earnings here increased only 30.4%. That sounds pretty bad, but it does not tell the whole story. One way that businesses have tried to afford to continue offering health insurance to their employees has been to shift more of the cost onto the employees. That has come through some combination of higher employee shares of premiums, higher deductibles and or copays, or reduced benefit plans. As a result, while employers' share of premium costs have gone up 56.6% in the past 9 years, the share that employees pay of those premiums has gone up 112.6%. Putting it plainly, the cost of health insurance has grown 2.7 times faster than employee pay in the past 9 years. That constitutes a major and growing burden on Louisiana families, and a major obstacle to regular access to health care. The impact on Louisiana businesses has not been pretty either. According to the U.S. Census Bureau, the percentage of Louisiana businesses offering health insurance to employees fell from 58% in 2000 to 54% in 2007. That still does not reveal the true extent of the crisis here. Estimates are that more than 7 out of 10 businesses in Louisiana are considered small businesses. Fewer small businesses have historically provided health care benefits to their employees, due to a number of factors, not the least of which being higher premiums associated with small risk pools. In Louisiana, small businesses have lagged behind their national peers in providing coverage. The current economic slowdown has widened that gap. A spokesman for Blue Cross Blue Shield recently told the Baton Rouge Business Report that only about 30% of Louisiana small businesses offer their employees health insurance, and that number is falling due to rising rates and a declining business environment. Large numbers of uninsured, rising premiums, a decrease in the number of businesses able to afford coverage. These are the elements that are combining to create a vicious cycle that is now undermining employer-based health care across the country, as well as in Louisiana. Here's how that cycle is pulling healthcare into decline. As we've seen, premiums for coverage have been rising fast, forcing companies to try to find ways to keep up. Failing that, they stop offering coverage to their employees. That adds to the number of people without insurance, erecting a barrier to care that was much lower when they had coverage. These formerly insured people tend to avoid doctor visits unless and until the symptoms of what ails them gets too bad to ignore. By the time they seek that care, the otherwise treatable disease might have turned into something justifying a visit to the emergency room. Those visits can get very expensive very quickly. The patient frequently does not have the ability to pay the entire bill. The hospital increases costs on services provided to those with health insurance, where the only compensation flexibility remains. The insurance companies will raise their premiums at the next renewal cycle to help cover the higher hospital costs that their customers now face. Those higher premiums force still more companies to drop coverage for their employees, reinforcing the cycle that will price still more companies and individuals out of the private insurance market. Another factor contributing to the problem is that there really isn't much of a market for health insurance in Louisiana and other states. Blue Cross Blue Shield of Louisiana controls more than 60% of the health insurance market. Add the number 2 player, and close to 75% of the health insurance market is concentrated in the hands of those 2 companies. Neither companies nor individuals have much choice when it comes to health insurance in Louisiana. This grim picture of Louisiana healthcare is going to get worse, with state government's budget woes playing a significant role in that decline. Medicaid is a health insurance program for children, the poor, the disabled. Costs for the program are shared by the federal and state governments. The federal government pays about 70% of the costs of Medicaid in Louisiana, one of the highest contributing shares in the country. While the program is publicly funded, Medicaid services are primarily delivered through private sector physicians, clinics, and hospitals. Because of our state's high poverty rates, Medicaid is one of the largest budget items in state government, even with the federal government's large contributions to that program. Like higher education, healthcare is one of only 2 major budget areas not constitutionally protected from state budget cuts. The 2009 session of the state legislature cut more than $100 million in funding from the state's share of the Medicaid program for this year. The impact of those cuts are not going to be limited to the people in those programs. In their August 4, 2009 statement in response to the state's Medicaid cuts, the Louisiana Hospital Association said the cuts would cost healthcare jobs and touch off an escalation in the practice of cost shifting. The association's leadership predicts that the current cuts will mean higher costs to those with private insurance, which will ultimately result in higher premiums, deductibles, and copays for those with private insurance. As we have seen, higher costs will force more businesses and individuals to drop their insurance coverage, which will result in more people not being able to afford timely access to care. The prospects for the future are grim. State government faces an even larger deficit in 2010. State political leaders have shown no appetite for tax increases, even those dedicated to health care funding. It means that still larger Medicaid cuts are likely next year. Those cuts will be much larger than those made this year, and, if the past is any indication, they will sharply accelerate the cost shifting that is undermining the employment-based health insurance system in Louisiana. Because of the scale and complexity of the problem, the significant role that the federal government plays, and the fiscal straitjacket that the state's political leaders have placed on themselves, healthcare in Louisiana is heading for a disaster unless there is an intervention. Part 3. Do the proposed reforms fit the crisis? There is general agreement that there are 5 elements at work in the current crisis. In order to assess the potential of any proposed reforms to respond to the crisis, we take a look at the elements of the crisis, then see if proposed reforms address those elements to determine if the reforms might work or not. The crisis in U.S. healthcare is a result of rising costs undermining the employment-based health insurance model that has prevailed here since the late 1940s. Among the factors driving costs are large numbers of uninsured who have limited ability to pay for essential healthcare services. Cost is a barrier to access to insurance as well as a barrier to access to care. As a nation, we are, in effect, rationing access to health care based on cost and the ability to pay. That inability of people to get timely access to medical attention ends up driving up the costs of care even further because diseases reach more advanced stages of development before treatments begin. In the current system, access to health insurance was once the surest way to determine if someone had access to quality health care. But steadily increasing price pressure has forced companies and individuals to assume larger burdens of healthcare costs through higher premiums, deductibles, and copays, as well as limitations on policies such as caps on lifetime expenditures. The second element of the crisis arises from practices within the health insurance industry itself. In their efforts to control costs and preserve profitability, insurance companies have developed strategies to sell coverage to the healthy and avoid covering those who are ill. Two elements of this approach are the pre-existing condition exclusion and rescission. The pre-existing condition exclusion allows insurance companies to deny coverage to people who are either already sick or have the potential to become sick. Chronic disease sufferers with health insurance are among those not able to get access to coverage from new providers, thereby locking them into existing coverages and even jobs because of the inability to get coverage elsewhere. Rescission is the practice of finding an excuse to cancel coverage or deny payment to a patient once an adverse diagnosis has been delivered by a doctor. Another practice that denies people access to coverage is the requirement of companies that new employees not be immediately eligible for health care coverage, even if they had coverage at their previous job. Health insurance is tied to the job and not to the individual. It is not portable. Once that particular job ends, so does the coverage. If a person leaves that job, then the company's contribution ends. People can buy the same coverage on their own until they can find a new job or new coverage, but it is a very expensive process, and difficult for families and individuals even in the best of economic times. The third element of the crisis is that health insurance companies make it difficult for people to act as informed consumers. Policies can be difficult to understand, and companies emphasize the elements in those policies that they believe make them most attractive to customers, while hiding information less favorable to them. These practices can obscure the implications of choices like raising deductibles or caps on coverage. In many states, one or two companies have come to dominate the market, limiting choices for businesses and consumers. In Louisiana, Blue Cross Blue Shield has 61% of the health insurance market. Add in the second largest company, and that accounts for 74% of all insurance coverage written in Louisiana. That is not a healthy, competitive environment, but it is the way things are in most states. The fourth element in the crisis flows from the fact that rising premium costs are forcing more people to go without coverage. People without insurance coverage frequently delay visits to the doctor when trouble arises due to the fact that, without insurance coverage, they can't pay the costs of those visits. The disease process can continue until the symptoms get too bad to ignore, and they are forced to seek treatment. Frequently, that treatment will be sought at a hospital emergency room. Because the symptoms were ignored and the disease allowed to advance, the treatments needed at this point will be even more expensive than if they had sought treatment earlier. Without insurance, it is likely that these patients will be able to pay only a small portion of the bill for treatment, if any of it at all. To cover these lost revenues, providers increase the costs on those patients with health insurance under a process called cost shifting. This approach drives up the costs paid by private insurance and drives up the cost of that coverage, putting coverage beyond the financial reach of still more companies and individuals. The fifth element of the crisis is the culmination of the work of the first four elements. Because cost acts as a barrier to care, many manageable diseases get out of control, damaging the health of those suffering from them, robbing them of their productivity on the job, and the ability to enjoy an active and rewarding life. People with untreated chronic diseases die younger than the rest of us, and the cost of providing them care in the later stages of those diseases usually falls onto government programs such as Medicaid and Medicare. So, the high cost of seeking regular care ends up socializing the cost of treating people in the final stages of diseases that could have been managed. Despite the near hysteria of opponents, the reforms proposed by President Obama and congressional Democrats actually address each of the elements of the crisis in ways that are based on a combination of regulation, market intervention, and the use of best practices. The reforms do not constitute a total overhaul of healthcare in this country, but seek to expand choices for businesses and individuals by restoring competition to markets, changing the behavior of insurance companies, and beginning the process of reorienting the healthcare system from one that treats sickness to one that promotes wellness. The proposals would expand access to affordable healthcare to every American by introducing more choice in the marketplace. Although the final form of the bill will not be known for several weeks, there is consensus among congressional Democrats and the White House that there will be some form of new affordable insurance offering made available in every state. That offering might come from health insurance co-ops, or it might come from a federal insurance program similar to Medicare or the state's children's health insurance program, but the plans will rely heavily on genuine competition in the marketplace to help lower the cost of health insurance. The proposed reforms would ban health insurance industry practices of using pre-existing conditions as an excuse not to provide coverage. Companies would also be barred from withdrawing coverage once a disease has been diagnosed. These two reforms alone will mean that more people can qualify for coverage. It will also likely mean that more small businesses will be able to buy coverage for their employees, including those with pre-existing conditions. The proposed reforms would create health insurance exchanges where companies would be required to list the costs and benefits of their policies side by side with those of other companies. This will better enable businesses and consumers to make informed decisions about the coverages they buy. Open listing of pricing will also inject a new level of price competition to the market that has been missing, as they have come to be dominated by one or two companies. By ensuring that everyone has access to affordable health insurance, the proposed reforms will sharply reduce the practice of cost shifting by providers to cover the cost of care provided to those without the ability to pay. Under the President's plan, everyone would have some form of insurance that would cover the costs of treatment delivered to patients in every setting. This will have the impact of reducing price pressure on private health insurance premiums, which should translate into reduced premiums and other savings to businesses and individual purchasers of private health insurance plans. The biggest impact on the reforms will be to enable the millions of Americans and hundreds of thousands of Louisiana residents with chronic diseases to seek early and regular treatment for what ails them. This will reduce the productivity drag that chronic disease imposes on businesses, and it will improve the quality of life on the sufferers of these diseases. The reforms also center on transforming the focus of the healthcare system from that of treating the sick to one promoting wellness by emphasizing better health choices. Regular access to care can enable that shift to take place. The most controversial segment of the proposed reforms has been the creation of a federally administered public health insurance option. The public option is viewed by proponents as a way to force private sector health insurance companies to be better corporate citizens by injecting a new level of genuine competition into the marketplace. Opponents call it a government takeover of healthcare, which it clearly is not. So what is the public option? The public option would be a government health insurance program for working-age Americans between the ages of 19 and 64. The health insurance crisis is centered on the issue of these people not being able to gain affordable access to insurance and health care. The public option is specifically designed for states like Louisiana, where the health insurance market has come to be dominated by one or two companies. The essential belief behind the creation of the public option is that health insurance markets can work if there is genuine competition in them. That competition is weak now. The public option will restore competition and shake up the marketplace. The public option is not socialized medicine. The federal government is not buying hospitals and turning doctors and nurses into civil servants. As in the case of Medicare, Medicaid, and S-CHIP, care would be delivered by private doctors and hospitals. Payment would come by way of the federal government. This model has proven successful in Medicare and S-CHIP. The only significant change here is that the public option will extend insurance coverage to working-age Americans at a time when the employment-based health insurance system is faltering. And, since reining in the cost of health care is a clear need of the current crisis, the public option brings the scale and reach of the federal government to bear in markets across the country. With that comes its ability to negotiate prices with provider groups and others to slow down the inflation that has outstripped other industries in recent decades. So, the public option, then, is an attempt to both stimulate and reform the health insurance marketplace while leaving private companies the room to operate. It will ensure that choice is restored to health insurance markets and that this element of choice is always there for consumers and businesses. Finally, what the public option and the other reforms will do is ensure that no American has to decide between their health and the financial well-being of their family. Dr. Mike Robichaux of Raceland knows the agonizing choices people can face.
And even people that have resources have to, and I see this every day, that even people with resources have to wind up taking all of their savings and put these savings into buying medicines and things that they need for end-of-life care and so forth. A family member, more or less to me, his father died recently, and before he died, he refused to be treated with some of the expensive medicines that he needed to be treated with because he didn't want to leave his wife with nothing. And so what little she has, she can thank him for sacrificing his life for her well-being. So those are decisions that don't make the headlines every day. They're very emotional decisions and very real decisions that we have to live with.
So the healthcare reforms proposed by President Obama and now being finalized in the Congress narrowly address the current healthcare crisis without constituting anything remotely resembling a federal takeover of healthcare. Thank you for watching, and for more information, please visit these websites. Good night and good health.